Welcome to the Inclusive Spaces Seminar Series at the Bartlett, the Faculty of the Built Environment here at UCL. I am Dr. Evangelia Chryssikou, Associate Professor, the Bartlett School of Sustainable Construction here at the University College London, UCL, and I'll be hosting this Inclusive Spaces session. Inclusive Spaces is a monthly online event series led by the Bartlett Equality, Diversity and Inclusion, EDI group, where we explore disability, race, gender, LGBTQI+, and many other dimensions of diversity and discover how they intersect with the built environment around the world. Today, you have joined the May edition of Inclusive Spaces, Environments for Mental Health. So, for the introduction, today it's my pleasure to welcome Professor Helen Kilaspi, and Professor who is a professor and honorary consultant in rehabilitation psychiatry at UCL, and Camden and Easington NHS Foundation Trust, and also Catherine Barrett, mental health service users, and since 2009 co-chair with Professor Helen Kilaspi of the Service User Research Forum at UCL. Now, about the session today, we will explore the architecture of psychiatric buildings with a focus on involving the end users in the design and planning of mental health care services and built environments. So, as I said, empowerment and architecture for mental health. So, how architecture can empowerment? What I have found out from my research, which spans since the 90s, actually, on psychiatric built environments. So, Professor Christensen, some time a while ago, so things might have changed, but not dramatically, did this amazing work at the Harvard Business School, where he classified all the pathologies according to how easy it is to diagnose them, how accurate, and how accurate we can offer a solution. So here you can see several diseases, like not only mental health, but also anything from fractures and cancers. What we see is that two of the most common mental health conditions, depression and schizophrenia, they are very close to zero, to the beginning of to access. That means that we have a difficulty to establish a very accurate diagnosis. Like, for example, we have an X-ray for fractures, and at the same time, it's a bit more tricky to give a permanent solution, again, like plaster for fractures. So, for this reason, these conditions are normally long-term, and people spend quite some time in psychiatric facilities. For that purpose, and going back to Christensen's diagram, medication, since we don't have such an accurate diagnosis, and we cannot have such an accurate intervention, like, as I said, you broke something, there is a plaster involved, and the doctor puts the plaster, and after a few weeks, that's gone forever. So we don't have that level of accuracy of intervention. But we need to give some importance to the other elements that are part of the therapeutic environment. So, and actually that happens in every healthcare condition. It's not only on mental health that we do have these elements. So we have the medical intervention, we have the therapeutic interaction with staff, and then we have also the space that this therapy takes place. But because here the first element cannot give all the accuracy, so you go to the hospital, you get the pill, and then you go back home and you forget about what happened. Here we need to place more emphasis in the other two elements, like staff and the built environment, because they cannot cure, at least the built environment cannot cure anybody, but the person will stay longer in these facilities, and also they can support or hinder the treatment. Therefore, their role, especially because of this long-term element, is very important. I will talk to you about 3 research projects that I have done. One is in the 90s, the other is in 2010, the other is somewhere between 2010 and 2020, and the third is more recent. The pictures that you see from like surrounded by blue and gray, they belong in the earlier part. And these pictures are healthcare facilities in France, psychiatric facilities in France, and the pictures in gray are psychiatric facilities in the UK. And I did a lot of research in these buildings, like involving patients, staff, but also some independent research involving the plans and the space alone, how I could evaluate. And then I repeated the research in some other facilities in London this time. These are the pinkish one. And recently we have done some work in New Zealand where there was some novelty there, because New Zealand, there is not only the Western medicine, but we have also the Maori medicine, and we have also a Maori population that are kind of different culturally. Through this work, I have developed a theory, the SCP model, where every facility can be evaluated. And the main axes that I believe are important are the safety and security of the environment, what competence allows for people to regain or retain, and the personalization of and choice of the end users. But what I have found in this research is some of the buildings that I would expect to perform better, and I mean some of the facilities that were quite famous when I conducted the research, and actually I came as an architectural researcher to admire those buildings initially for their architectural qualities, and these are the 2 buildings on the top, performed very bad, both from the perspective of what the end users and the staff said, but also from my methodology that was completely independent from what people said and suggested. And actually, they had one of them the same exactly score with a facility in France, which was not therapeutic at all. People reported many social problems. And here we see, for example, a typical bedroom, and this was a 3-bed facility, most of them, where it was a woman's facility, and you can see here 1 bedroom, but there are another 2 beds. 1 bed, but there are another 2 beds in the room, and hidden behind the curtain is the toilet. So no privacy, humiliating conditions, but the scores and the responses of the people were kind of similar. And if I go and I show you all the facilities that I have seen, that I have used the same methodology throughout the years, the two buildings that I mentioned, that were also the buildings that had received a lot of awards, they are ward number 2 and ward number 6. And the scores are kind of high because ward A and ward B belong in a different time zone. So ward 1 to, like the ones that have the Latin numbers, are the ones from the experiment in France and the UK, the original research in 2000. So these two projects, the awarded ones, one was among the second worst in the sample, ward 1 was the worst. It had equal score in how institutional it is, like the highest the score, it shows how institutional the facility is, the building is. So it was equal institutional with the ward with the toilet in the middle of the rooms. And in that facility also, the one with the toilet, there were also many other social problems. And also, yes, and some facilities that were kind of typical were between 47 and 41, and one was 56, extremely poor. But as I said, the two awarded were alarming. And there were two facilities that did exceptionally well. So Ward 9 and Ward 10. These two facilities, they were designed from the beginning with the contribution of the service users. From the first stages of planning, the service users had a strong say in these facilities, and that actually reflected both in the how less institutional they look, more domestic looking, but also these facilities were the facilities that staff and service users were happy with the building. Now, and here, this is something that the two that you see with the yellow, these are recent facilities. So it's a recent research project, but one of them is actually more modern than the rest, and they are very institutional. And on that, I was surprised. I thought I did something wrong, but then I found research from Professor Kilaspi that says actually that mental health facilities in the community can be quite institutional. And we don't necessarily really solve or make things better as we progress. At some point after this research, we did another project where we compared mental health facilities with health facilities in the community. And we found a lot of comparisons and a lot of analogies, but the mental health was always the poor relative. And here you see part of the St. Pancras Hospital and part of the a children's hospital in the same catchment area. And that is also very obvious on how not only the buildings look, but where they are located. And psychiatric facilities, they tend to be away from transportation and kind of in the periphery and hidden away, which requires a lot of time also for staff to get there. And that led to a project that we did for St. Pancras Hospital then, where they realized that in the new buildings that they were building, they had to involve the patient and they had to empower the people. So we prepared a consultation with the hospital on the briefing stage of the planning of the new hospital, where we needed to empower the patients. We tried to give examples, international examples to the patients, that psychiatric facilities are not forgotten and actually they are designed. Maybe we don't agree with all of them, but I want to show the approach of something else, something different happening somewhere else in the world. And this facility, it's a bit controversial. From outside, you can see how intense is the treatment inside. I don't say I would agree. It reminds me more of, but it is an interesting example. This is something that I found by researching in a facility, again abroad, that service users, before leaving their room to go back, they actually prepared a small gift for the next person that will use their room. And that was like another type of involvement from the service users to say, I'm here, I was here, like you are coming here, and I prepared something for you to remember that you will get out, like I got out, and also something that I believe will help you. So, and that was a nice practice, I don't know, that I liked. Something that I liked in this psychiatric facility was that there was a gym, and sorry for the presentation, somehow has a mind of its own. But, and this was something that most of the service users actually wanted when I was asking them what you need in your work, because they spend a lot of time indoors. And so I like that somebody actually did it. And finally, that's another project that I really liked, that is in Ljubljana. And I was there for a public health event. And I spotted a shop in the most expensive area of Ljubljana, in the most expensive spot, where normally you would expect a luxurious jewelry, for example, store. But that was a project run by end users, and actually that was products created by artists and products created by service users. And it was run by service users. And actually in the till, there was a support line for people to call or to come and chat and engage. And for me, that was very important, not only because it was a very beautiful and successful gift shop, but also because it was in the heart of the city, in the prime location where you don't normally find something related to mental health. Because mental health, as we saw in the other project, is pushed towards the periphery. But here it was a joint project with the service users and the artists, and obviously the health services of Ljubljana, that truly is a unique example and makes a great example to be repeated everywhere. And finally, something else out of the box. In Paris, there is a day center that is like the bateaux mouche that travel around the river. And in the past, like many, many centuries ago, boats were associated with mental illness as they carried patients across the rivers of Europe. But here, having such a beautiful day center in the biggest attraction of Paris, which is the river, I would say it's something very destigmatizing and give us hope on what we can achieve. So that's all from me. Thank you. I will stop sharing and I will welcome Helen and Catherine.
Hello there.
Hello, everyone.
So, Leah, thanks very much for your introduction to this whole area. My name's Helen Killasby. As Leah said, I'm a professor in rehabilitation psychiatry at University College London. I'm also a clinician. I work half-time as the psychiatrist for a community mental health rehabilitation team in North London. And Leah's asked Catherine and I to talk to you about our service user research forum. So I'm going to say a bit about how that forum came about, and then Catherine's going to talk about her experiences of being a member and for many years now the co-chair of the forum. And then we'll have time after that for any of your questions that you've posted into the Q&A. So we started the Service User Research Forum. I'll call it the SURF from now on because that's quicker. So we founded the SURF in 2005. The reason that we did that is because up until that point, the process of involving service users in the development of research protocols, research funding applications was really very tokenistic. funders would expect us to be able to write something about patient and public involvement, or PPI, but it was often just a very small line in a funding application and a tick box, and it had to be signed by a lead service user. So that the process basically was incredibly tokenistic, and there was a particular service user who was very involved with the local mental health organisation, who tended to just sort of lend his signature to those forms. So it didn't feel like authentic service user involvement or consultation at all. And so we set up without really any without really an awful lot of thought, this idea of a service user research forum. We put an advert out for service users who might be interested in coming to hear about it, and we held a meeting or two to tell people what we were thinking, and about 30 or so people came along to the initial meetings. And over the time that the forum has been running, that initial group of 20 to 30 people has really established a core membership of more like 12 to 15 people. And we meet every 3 months or so at University College London before the pandemic, and since the pandemic, online. And the format is consultation. So the meetings usually involve 2, sometimes 3, but more commonly 2 presentations from researchers who want to talk about their project to get feedback from service user experts. The kinds of projects that are discussed is quite broad. There's often a focus on health service research, obviously for our population mental health services research. So applied clinical research, neuroscience, applied clinical neuroscience. Sometimes people are presenting studies that are evaluating new interventions, psychosocial interventions. Sometimes they're wanting to talk about new technologies, apps, and other kinds of technologies. So it's quite a broad range of topics that might be brought to the SURF. I guess over the time since we've been running, now it's 18 years, it's something like 150 projects that the SURF has consulted on. We give a little bit of guidance to people who are presenting their project to suggest that, they might want to send a brief summary ahead of the meeting so that the members of the SURF have time to sort of think about the project before the meeting. And if the researcher wants the SURF to give specific feedback on any particular aspect, then obviously they should focus on that when they're talking to the SURF. They usually have about half an hour to 40 minutes or so for the discussion. So it gives enough time for people to hopefully get whatever feedback they need. The other part of the SURF is, as well as providing this sort of consultation function, what we also do is to provide the opportunity for researchers to invite, if they would like, a service user or more than one service user to join their project, for example, on their project management group or steering group, or as part of their service user reference group. Sometimes SURF members have been employed on projects as researchers, collecting data, interviewing, co-facilitating focus groups, and then they might also be involved in analysing data, interpreting results, and giving advice on recruitment, also helping with the writing of papers and presenting at conferences. So basically the sort of the SURF experience is also building research capacity for SURF members. And that was a process that evolved over time. When we first set up the forum, some of the members really wanted us to sort of train them to be researchers. And the SURF, when it was first funded, had no funding. We had a very, very small amount of funding from our mental health organisation and the university to pay the SURF members a little for their time. And so this process by which actually people then link in to studies that have been presented at the SURF has provided a much better model for service users to gain hands-on research experience if they want to. And that's been really successful. And I think pretty much all of our SURF members have had at least one of those roles over the years, and many of them have many roles and take these sorts of positions on with specific research projects very frequently. I mentioned that all the SURF members are paid. Of course, they're paid for attending the meeting. We used to fund that through asking researchers to pay a consultation fee if their project was funded. Often people will come to talk about their project before they've submitted it for funding, so we don't charge them at that point. But if they're successful and their project is funded, then we ask them to potentially pay back a fee for their consultation that they've had with the SURF. And quite often people will build in further consultations as part of the PPI for their project. And of course, those also need to be funded. That was quite a precarious funding model, because we see a lot of researchers who come to the SURF and talk with us about projects, and of course they don't all get funded. And also it's kind of embarrassing going around and having to contact people and ask them for money after the event. So I'm very pleased to say that for the last 9 years, we've been funded in a much more robust way through the Biomedical Research Centre at UCL's mental health theme. And so that has really, really helped us feel that we've got a much more secure footing. I guess the other sort of USP about this model is that most PPI in research studies in other fields, not just mental health, will invite people to give their perspective on a project because they are service users. Absolutely right. That's what researchers want. They want to have service user perspectives on their research idea, the rationale for the research, and then the specific methodology and other aspects. But what SURF allows is for us to have built this sort of expertise amongst the members of the group. So yes, they definitely give their views based on their own personal experiences of having mental health problems and using mental health services. But they've also over time, of course, gained this expertise around research methodology. And so you're getting kind of 2 for 1. So they understand the potential tensions and difficulties and the different sort of payoffs that researchers have to make when designing a project to fit within a certain time frame and a certain budget. So it has felt as though it's been rather a sort of organic development of this model. It's been really successful, and we never have a shortage of people wanting to present at the SURF. We often have to organise additional meetings because we have too much demand for our quarterly meetings. And I guess the fact that it's been running all this time, 18 years, is also some evidence that it seems to be providing some useful service. I'm going to stop talking now to give Catherine the opportunity to say a few words. And so I'll hand over to you, Catherine, if that's okay.
Thanks, Helen. Thank you. Hello, everyone. Yeah, so I'm a mental health service user, and I'll tell you a little bit about the process of the Service User Research Forum. It runs as often as we need it, really, but usually about 4 or 5 times a year, and we meet online for 1.5 hours. And as Helen said, the participants are paid, which is great. There's usually 2 to 3 presentations per meeting, and they are usually UCL researchers, but sometimes the researchers are from other organizations. Each presenter has about half an hour to present and get feedback from the service users present. They often present on PowerPoint, and then there's plenty of time for questions and answers. This involvement is great for service users as we hear about research being conducted and how the SURF helps researchers refine their studies to gain successful applications. It also helps service users gain confidence and learn about the relevance of mental health research. I feel this format is just right for the group. It allows plenty of time for question and answers, both from the presenters and the participants, and works well online. Sometimes the researchers want more involvement from participants, so extra involvement is arranged. Co-production of research proposals is highly valued by researchers at UCL, and SURF members find their role highly stimulating and rewarding. The fact that SURF has been running for so many years is evidence of how much it is valued and used. We had strong views on one presentation we had recently, videos on the ward, and the participants don't want to see this on Camden and Islington wards. They didn't like the subject. It's not often there's such strong views about a study as this presentation, so it's important for the researcher to hear. It was all about cameras on wards. The participants didn't like this idea at all and had strong views, but that's not usually the case. Usually there's equal participation from the presenter and the participants. Everyone has a voice, and it's important for everyone to have the opportunity to share their perspective and views on the SURF meeting. We are a friendly bunch who are polite in allowing everyone to speak. Everyone is encouraged to participate. Researchers have good comments about SURF. We're often very positive about the projects and realize all of our hard work has gone into their presentation and realize all of the hard work that has gone into their presentation. As co-chair of the group with Helen, it's great experience for me. It has helped service users to learn about the relevance of mental health research and the processes involved in delivering good quality studies that can help improve people's lives. I look forward to SURF meetings. They not only provide stimulation, but are also helpful to researchers. So it's a win-win situation. Thank you.
It certainly feels like that, doesn't it, Catherine?
Yeah. It's really good.
The study Catherine just mentioned, I don't know if this is happening in other countries where you may be working, but increasingly in the UK, in inpatient mental health wards, staff are potentially having body cams on their uniforms, or there are cameras within patients' rooms and communal areas. And this is sort of sold as a way of trying to improve safety in these settings. And as Catherine has said, actually, of course, there's a huge human rights infringement issue here. And so that was a particularly lively SURF meeting. I mean, the researchers were wanting to evaluate the impact, including service users' experiences and views on it. But it was very clear. It almost got to the point where people saying, we don't need research, we just don't want this at all. Just, let's not evaluate it. It's just a bad idea. But unfortunately, these things have already been implemented. So as Catherine says, quite often that the topic of the research isn't as contentious as that. But we do have a really lively discussion, and there is sometimes quite a robust exchange of views about different aspects of a research, or even whether the members feel that the research is worthwhile, is the actual main objective of it worthwhile. More commonly, though, it will be a discussion about a specific aspect of the research. The researchers might bring the topic guide for qualitative interviews and ask for more precise and specific detailed feedback about the areas that are going to be covered, or they might be asking about strategies for recruitment into the study. So it covers the whole range really of research thinking, right from the design stage right through to dissemination, and all of that can be covered in these fora. So I think we're at a point we'll be very happy to answer any queries or questions, or just have a broader discussion, Leah.
Yes, so thank you, Helen and Catherine, for the presentation. Indeed, I mean, the group does a wonderful job. I'm looking at, we have like a couple of questions in the chat. The first is from Shmuel Yerushalmi, but it is addressed to me, but I will address it to both of you actually. And that's about the role of the government and public medicine system in empowering and improving mental health, which if I can mention here, because for me, actually, this session is about the opposite. It's it doesn't matter what the government or the central systems do, what we can do as people and as end users, and giving power at the service user, either for the buildings or for the research. For me, that's the ultimate act of empowerment, giving a strong voice and giving it in a way that should be heard, like structuring the voice in a way that it's not, as you said, one service user that is involved in all the project and it's the voice of the person, but making the collective voice important and clear. So actually, yes, the discussion is about the opposite, because I think this is what is missing. But your opinion on that as well, please.
Well, I think you're absolutely right, Leah. I mean, the purpose of the SURF was to really try and set up a structure that would have a collaborative culture and that would really empower and enable a group of people who have, all of whom have experienced mental health problems, and many of whom have experienced severe mental health problems, to have their voices heard. And in this particular focus of it, of course, it's on research and research design, mental health research. But that's a culture, this kind of trying to create collaborative forums to enable service users to give their perspective is a culture which really has improved in the UK, at least over the time that I've worked in mental health, which is about 30 years. We never used to talk about this term co-production, but that's very much the kind of term these days that people use. I would say co-production is one end of the spectrum of service user involvement. Consultation is at the other end, and the SURF is more at the consultation end of that spectrum than the co-productive, but it's a very collaborative style that we foster. I mean, my personal view is that all mental health services should foster and provide a collaborative culture at every aspect of the service level, but certainly in the individual interactions with service users, between staff and service users, but also at the team level, at the management level, at the organizational level. And actually, collaborative discussion is it can be quite a skilled thing to facilitate a collaborative discussion, particularly if there are very strong opinions in the room. Also, if somebody isn't very well, and so they might be, taking a lot of the time or repeating the same point because they're not currently very well and less able to sort of be able to be aware of other people's needs. So, those sorts of aspects of making this work in a mental health setting have to be considered as well. And I think we have managed to do that. I mean, Catherine and I, we won't go into detail, but over the years, there've been one or two times where we've had to sort of have a separate conversation to think about how to manage difficult situations. And we've managed all of them well without people becoming, annoyed or alienated or anything like that. But sometimes we do have to sort of just tweak the way that we're managing some of the forums. But I think basically this sort of idea of a collaborative culture, a way in which we provide opportunities for people to be heard, that actually is what changes the quality of care. And, of course, you've given lots of examples of where the built environment lets us down terribly, and it really does. It's also true that we can do excellent work in dreadful buildings. It's not, we want both ideally, but it is possible to run an excellent service even when you're running it out of a shabby building that has very, very poor facilities. So, more investment means that we can improve quality, but just throwing money at things doesn't work unless you also are clear what you're going to spend that money on. We did a study across Europe some years ago looking at longer term mental health facilities across 10 European countries at different stages in their development of community mental health services. So some of them were countries that still had most of their mental health services in large inpatient institutions, and others had more community-based, smaller facilities. And we developed a measure to look at the quality of care, and it included an aspect around the built environment, but also all sorts of other aspects of quality of care. And we did some modelling around the investment that the government makes in mental health and its correlation between that proportion of the total health budget and the quality of care in longer term facilities. And there was a very clear association. The higher the investment in mental health by the government, the better the quality of longer term mental health facilities. So in a way, the quality of mental health facilities gives you a sort of benchmark as to how much the government cares about mental health. And we also found that there was a sort of sweet spot, and it was around 10%. If the government invested 10% or more of its health budget in mental health, then the quality of longer term mental health facilities was above the European average. So we kind of know how much they should be investing for us to have adequate facilities for those with the most complex and longer term needs. That was quite a long answer, sorry.
Thank you, Helen. I mean, for us, we have, obviously, I mean, funding is important. For us, the interesting project with the comparison between mental health and healthcare services was that the budget at that time was quite high for mental health facilities. But but still, I guess maybe the ratio of the funding for the building compared to a health facility might be different, or the attitude. So I still believe that money is important, but it's not necessarily going in the right direction. I mean, that's what the research on that involved the awarded facilities showed, that the expensive facilities that were awarded were in the wrong direction, because, for example, they had a garden that the service users could not access because it was not safe enough for them, and there was drug trafficking in those gardens, so people spent time. So it was bad design decisions. And also in mental health facilities, the building is the only equipment that you have. In a hospital, you have a lot of machines and diagnostics and very, very complex technologies that occupy the budget, and also they have a direct impact. But in psychiatric architecture, there's no equipment. So it's the building, and the people will stay there for months. So if you get it right, they will be in the place they need to be. If you get it wrong, they will be like in a prison for months. That is bad for them. So, as I said, the impact is quite different. But yes, as I said, the end user involvement, I believe it's still very, very important, even when the funding is there. As I saw from my research, somebody is asking, Eunice, is asking what SURF stands for.
Service User Research Forum.
Yes, thank you. And people are asking if you are involved in the development of architectural projects, not research projects.
So, well, Leah, you've brought your projects to the SURF for consultation, so you've had the direct SURF experience yourself a couple of times.
It was a architectural research projects, yes.
Indeed.
Yes.
I think, I mean, Catherine, you might want to speak to this about your involvement when there are new designs within the mental health estates within the trust.
Yeah, we've been fully involved. There's a new hospital being built at Archway near the Whittington, and the St Pancras site wards are all moving there shortly, and we've been very involved in co-producing the development with the architects, so that's been great. That's been going on for a few years. There's also a big development in Holloway of the CMHT. They've flattened it and they're rebuilding it. So there's a lot of work going on in Camden and Islington with new buildings, and this will all be being used within the next 2 years. I think the aim is to move the wards from St Pancras at the end of this year. So yeah, it's been great to be involved with the architects, and they really did listen and change some of their thinking with our input.
That's good to hear. I can see there's
Yeah.
also a question about feeding into things like the colours and the specific design that's chosen. Did you feel that those were picked up?
We did talk about the colours and the design, definitely.
Yeah.
My experience from that consultation, because we were involved, at some point at the beginning, because this was a massive consultation for the St Pancras Hospital. I mean, it was very successful by the amount of how many staff were involved and how many patients were involved, and it was a very, very active space. Initially, it was at the planning stage. Somehow the planners and the architects were not familiar on how to listen to the end users, and because I was there in all the meetings, like for the new hospital, it was so I guess also the fact that there were people experienced in giving feedback from the end users, but also we had the project that we did to prepare everybody who was not familiar with such processes in order to gain their voice. And this is a recent work that we have on how you need to prime the end user in general, not only in mental health, in dementia, in other healthcare projects, especially, but mental health is very important because there is a history of institutionalization and everybody is deprived of their opinion for many, many centuries, not years. So it's difficult to have that voice. So I guess, I mean, you are doing that with SERF, and that's the purpose of SERF and the success, but it's not easy for somebody who is not well in general to give feedback, and it's not easy out of the blue to give it. It is intimidating in the beginning. Like, you see people that have studied those things, have a strong opinion, and then you feel that you cannot raise your voice and say, I disagree, or things might be different. And this work of priming, preparing the ground for the voice to be first raised and then heard. And I think that's the important contribution of SERF, because there has been work there on how.
I think that's right, Leah. And I think, as I was talking about before, that, when we first began, the first meetings, researchers might come and present a project, and it would be hard for people to have many comments to make because they didn't necessarily feel that they had the expertise to say, oh, I don't think that's the right approach here. But over time, of course, people have got much more familiar with how research projects are designed, and it's the same if you're thinking about what's the process for a redesign of a building or building a totally new facility, that you need to be empowered to know what you can comment on. So if you raise a point and somebody sort of shuts you down in a kind of, oh well, no, that's not really negotiable kind of response, then of course you don't feel you can say anything again. So giving people the opportunity to understand, and that's one of the reasons that we ask researchers to send a brief summary of their project before the meeting. People often need time to process, to read, to have a think. There are cognitive sequelae of severe mental health problems, and people sometimes need some adaptations to be able to take information in. And so if a researcher comes with a large number of PowerPoint slides, very technical, lots of data, you just lose the audience very quickly. And I think we have done that now. I think we do know how to do this in the SURF format quite well. But pictures are much better. In fact, we generally discourage people from using PowerPoint in our SURF meetings. I mean, some people do, and we just make sure it's as minimal as possible, because actually it tends to be a distraction. It tends not to help. What helps is explaining it in words. It's also good practice for researchers to be able to explain their research project simply in a way that a member of the public can understand it. I see there's a couple of other questions, aren't there, in the Q&A?
There are questions about mostly if your work could be extended outside the institutions to the city level, to public mental health.
I've not done that myself. I mean, I work in the community, so my research is on, the services and the interventions that go on within those services to help people live as independently with as high a quality of life as possible in the community. I must say that, we have little research, in my experience, on the outside space in mental health facilities. I think there's a bit more focus on that for inpatient facilities, but for things like mental health supported accommodation or community-based units, I think people don't think about it enough. They tend to get very focused on the building and the rooms in the building and the office space for the staff and the consultation rooms, and they think a bit less about the outside space. And actually the outside space is very important, because if people are attending a centre for appointments, it's quite common that they will want to have a bit of time outside before they come in for their appointment or after they've had their appointment. So we should think about it more, but I'm not aware of any specific research on that.
Yes, it's the project that we had about the comparison of mental health. We didn't look inside the buildings. We looked only on the facades, what people do from the outside. We didn't think of it like, as you said,
Yeah.
But we thought what community sees, because it's what other people see about psychiatric buildings and then how they are predisposed and how the stigma can be generated. But yes, this threshold, the space just before you enter, I guess must have, like, as we prime for the consultation, technically we prime the people for entering the facility. It's very important.
It is.
So that I see there is Argyris has a question about the indoor air quality. I mean, I have some data, because I have a lot of great data that I didn't have time to publish, but about how people felt, etc. So if you want, we can discuss it at one point, since we are both in the same institution. But I guess it's a very important topic, especially the windows don't open in most mental health facilities. And it's not so much of the thermal control, it's also, there is if you have ever been in a psychiatric facility during a heat wave, and I have happened to do research, it is very difficult, not for the patients. It's very difficult, even for me, it was extremely difficult. So I think it's a very important topic.
Absolutely, it's horrific, is the truth.
Yes.
And the last few summers have been awful. The windows in our newest mental health facility in North London, as you say, of course they don't open for safety reasons. They have vents. It doesn't allow any throughput of air. It feels very suffocating, and of course that cannot be good for people's well-being. So I think there is a research question in there, actually, about temperature control.
The temperature, the air quality, and also I would connect it to the access to the exterior space. This is something.
Yes.
Like the exterior, the internal exterior, like from my experience, and I said also personal experience, that was a very, very big problem.
Yeah.
There are many aspects there of safety, security. It's actually, when I saw the model that says about safety and security, and the other axis that says about control, it's these two axes, they have a very strong argument there between themselves. I need to solve that.
Yeah.
And yes, I think we are a little bit close to the end. We only have 1 minute. It was wonderful having your questions. Unfortunately, when we had such a lively audience, we didn't have time to refer to all of your questions, and which is a pity, but I mean, a researcher is always easy to find. Both me and Helen and the SERF group is very, very easy to find our emails from the UCL website, and in that sense we will be very happy to discussing with you and answer your questions.
And just to add, Leah, I think there was one query about whether the SERF is just open for sort of UCL people. We tend to work with anyone who's working across North London, but we're not actually that close to working with anyone. So if if somebody wants to use the SERF to consult who doesn't happen to be working in North London, I'm sure we would be open to that as well. If we can help, we will.
Yes, and we have done. I have done a SERF group with researchers from Germany.
Yes,
So, yes,
indeed.
lucky. So to wrap the session, I would like to thank everybody for joining us today. A big thank you to our panel for your time and contribution to the discussion. Thank you all very much, and have a nice day.
Thanks very much. Bye-bye.
Bye-bye. Thank you.